Ameloblastoma has always intrigued me since my early days in dental school in my third year when we come across odontogenic tumors in our Schaefer textbook, and where there is a picture of an African woman with grotesque swelling and the various histological variants. Since then, it has always intrigued me, and we have come a long way since then, of course. And ameloblastoma has also evolved a long way since then over the years, with so many new theories coming up in its etiopathogenesis, as well as in its classification in histopathogenesis, and of course, regarding the treatment modalities. Now, to start with, tooth formation is a complex phenomena, and the complexity lies because of induction of both ectodermal and mesodermal complex, plus varying signaling pathways and genes which are acting in the development of tooth. Now, any dysregulation which occurs in any of this growth and development phenomena would lead to odontogenic tumors. Now, amongst them, ameloblastoma being one of them. Ameloblastoma has been classified as a benign tumor which is locally aggressive and that forms from odontogenic apparatus within a mature fibrous stoma devoid of odontogenic ectomesenchyme. It usually poses as a painless swelling that acquires a grotesque swelling if not examined and diagnosed at a proper time. This is particularly seen in patients in developing countries where healthcare facilities are limited and there is delay in diagnosis. Now, as our books have described ameloblastoma, that it comprises of 1% of all tumors in the jaws. Since then, now the data has changed considerably, and what we see is that now its ratio or its preponderance amounts to 2 to 4% of all jaw tumors and cysts. And the odontogenic tumors, within odontogenic tumors, it is the second most common tumor occurring after odontome, and it amounts for 11 to 18% of all the odontogenic tumors, mean average being 14%. And this has happened, this has evolved over the time. And in the past decade, all these, there has been a change, what we have seen. It is, the global incidence is 0.5 cases per million per person per year, and it is highly encountered in Africa and China. Now, earlier, the age range was with the middle-aged individuals. But what we see now, that there is no age preponderance, and we can see ameloblastoma occurring right from pediatric cases to the geriatric cases. And also, this varies from continent to continent. And the prevalency of pediatric population is seen more in Africa and Asia. Similarly, earlier what we've seen, what our book said, were the sex predilections were more in males as compared to females. But now again, this data has also changed, and what we get to see is there is no sex predilection. I mean, males are equally affected as females. Also, this will be variable from continent to continent, region to region. Now, coming to etiopathogenesis, this has evolved over the years, and it is yet to be conclusively established. But what we understand now is what we understand that what the earlier theory said about the etiopathogenesis was that trauma, nutritional deficiency, or any non-specific irritation could trigger the possibility of ameloblastoma. And of course, the remnants of odontogenic apparatus and lining of odontogenesis still hold true. They cannot be ruled out. And importance of stratum intermedium. The presence of stratum intermedium is equally important for functioning of ameloblasts. In present times, at the molecular level, the genes, there are various genes which are involved in tooth development. Now, any dysregularity in these genes would lead to development of ameloblastoma, or probably could be any odontogenic tumor for that matter of fact. Now, in ameloblastoma, there is a complete group or cascade of genes and the signaling pathways which are overexpressed or underexpressed relative to normal. Now, this is a table which comprehensively gives us a review regarding the various markers, genes which are getting affected in ameloblastoma. Now, the first amongst them is the group of stem cell markers, that is your CD133 and BMI1, which are overexpressed in ameloblastomas, in ameloblastic carcinomas and metastasizing ameloblastoma, leading to oncogenesis, cytodifferentiation. Next, coming to the signaling pathway. Now, the sonic hedgehog. Sonic hedgehog is a key regulator in embryonic development, and it acts through activating transmembranous protein patched and smoothened. Now, when there is combination of SSH with patch, there occurs release of SMO and gliomyoma associated transcription factors which are activated. Now, this entire complex is overexpressed in ameloblastomas, and it leads to proliferation, and it is also seen in benign as well as metastasizing ameloblastomas. Next, coming to our TGF-beta pathway, which is regulated by SMAD proteins. Now, what happens is SMAD functions in tumor suppression, but mutations over here leads to tumor progression, invasion, and aggressiveness of the tumor. Enamel, next comes in this category is enamel matrix protein. Now, enamel matrix protein calretinin has been seen to be overexpressed, which leads to dental remina remnants to transform into ameloblastoma. Next, coming to cell adhesion and migration markers. Now, these are group of markers. They are either overexpressed or underexpressed, leading to aggressiveness and invasiveness of the tumor. Now, here we have syndican 1, which is overexpressed, underexpressed, cadrins, keratin 7, and notch. They form a complex, and there is loss of this gene complex. So basically, loss of these two complexes would lead to tumor progression and invasiveness. Then we have integrins, which are overexpressed. Then we also have claudins, which are underexpressed, and they lead to invasive behavior. We have podoplanin and metallothionein, which are overexpressed, and they lead to basically invasiveness, tumor growth, and metastasis. Then we come to cell proliferation markers, which are P16, Ki67, cyclin D1, telomerase, and PCNA. Now, all these markers are overexpressed, and they lead to increased aggressiveness, recurrence, and malignant potential, and thereby leading to poor prognosis. It has been seen that Ki67 its expression is more around the peripheral cells as well as of ameloblastoma and the basal cells in the unicystic ameloblastoma. thereby causing high recurrence rates. Coming to next, we have our tumor growth factors, the FGF1 and FGF2, which are overexpressed both in the ameloblastic cells as well as in the basement membrane, thereby giving rise to tumor growth. FGF7 and 10 are also overexpressed, and this overexpression leads to dysregulation in MAPK pathway. Coming to angiogenesis, which is a fundamental factor in metastasis. Now, here we see platelet-defining growth factor alpha levels, which are increased in malignant ameloblastomas and thereby leading to metastasis. Next in this group, we have our apoptotic markers. Now, apoptotic markers, basically apoptosis is controlled by large family of genes. Now, here what happens is tumor necrosis factor alpha and its receptor R1 and R2 are overexpressed, leading to dysregulation in MAPK pathway, thereby inducing cell survival and proliferation. Fast and fast ligands are overexpressed in the central cells of ameloblastoma, converting them into granular and acanthomatous type, giving rise to cytodifferentiation. BCL2 is also overexpressed in peripheral cells, causing tumor growth due to anti-apoptosis and cytodifferentiation. Then we have caspase-3, which leads to cell death within the central areas of the tumor islands, thereby leading to cyst formation. Next amongst this group is our tumor suppressor genes P53, P10, which are cascade, and any alteration in this tumor suppressor cascades, and there is alteration in this cascade leading to oncogenesis and malignant transformation of odontogenic epithelium. Allelic loss of P10 gives rise to aggressiveness of ameloblastoma. Furthermore, we have extracellular matrix degradation markers, which are MMP 1, 2, and 9, which degrade type 4 collagen in the basement membrane, leading to tumor invasion and metastasis. Then we have our bone remodeling markers. Now, this particular bone remodeling is controlled by parathyroid hormone receptor, which in turn regulates rank-rankle pathway, which is further regulated by osteopontegrin. So what happens is this entire complex is controlled by parathyroid hormone. There is overexpression of parathyroid hormone, which in turn causes increase in dysregulation in rank-rankle pathway and dysregulation of osteopontegrin. The entire complex is altered, leading to excessive lesional bone loss, thereby invasiveness and expansion of bone. Then we have osteopontin, which is again one of the regulator in bone remodeling. Now, what happens to osteopontin? It binds itself to tumor cell membrane receptor CD44B6. Now, this causes enhancement in tumor cell growth, migration, invasion, and spread. So, increased overexpression of this complex is associated with high recurrence and metastasis in both unicystic and multicystic ameloblastomas. And finally, we have tumor stromal cell marker, which is CD10, and its overexpression causes high recurrence in conventional ameloblastomas and local invasive behavior. Next, coming on to now, all this has been studied since past decade. In the New York Times, it is the critical step in pathogenesis of ameloblastoma now has been attributed to activating mutations in FGFR2, BRAF, and RAS, leading to dysregulation of MAPK pathway. Now, this has been, there are many workers who worked on this. However, Brown et al., Sweeney et al. In 2014, 15, 16, with their extensive study, have come to a conclusion that BRAF mutations amount for almost 63% of all ameloblastoma. BRAF is a serine threonine kinase protein where valine mutates and replaces glutamine at 600E locus. Now, BRAF mutations basically correlates to several clinical features which are seen in ameloblastoma. That is the location in mandible, the age group, which is younger age group, variable histology, and possible prognosis. Now, MITKINE, which is again a heparin binding growth factor, is also overexpressed, leading to dysregulation of MAPK and protein kinase B, that is your AKT pathway, leading to development and progression of tumor. Mutations are also seen in non-MAPK signaling pathway, that is in SMO, which is a G protein couple receptor and signaling effector component of SSH signaling pathway. Now we have another group which accounts for in the pathogenesis of ameloblastoma. MicroRNA system, which regulates expression of many human genes, and that this regulation leads to neoplastic development. Now, what happens? Olara et al. Have studied almost 40 microRNAs in ameloblastomas, and what they found that there are top-ranked 6 microRNAs which are elicited in unicystic ameloblastomas and 7 in conventional ameloblastomas. However, there is one common microRNA which is 489, which is elicited in both types, differentiating between solid and unicystic ameloblastomas. Next amongst this was found again, this is again which has been put forth by Kang Y et al., that periostine, which is an oncogene, there is overexpression which leads to bone lysis and thereby expansion. It has also been seen in present times that yes, associated protein or YAP is overexpressed in the peripheral and the basal cells of ameloblastoma and having a possible role in invasiveness and aggressiveness of the tumor. So this entire thing gives us a comprehensive detailing where all these genes, the protein markers, are responsible in development of ameloblastoma. Now, it could be anything right from conventional ameloblastoma, unicystic ameloblastoma, or the malignant types. Next, we move on to advances in histopathogenesis. Now, what we have seen over the period of time, that WHO gave classification in 2005, where ameloblastoma was divided into benign and malignant types. Benign constituted of solid multicystic conventional type, then unicystic ameloblastoma, peripheral or extraosseous type, desmoplastic ameloblastoma, and the malignant variety, which constituted of primary ameloblastic carcinoma, secondary arising intraosseously or secondary arising peripherally. This classification was modified in 2014 by Wright et al. And what they did was they removed desmoplastic ameloblastoma from the classification and putting it as definitely as a histopathological entity, aiding in diagnosis, and divided the unicystic ameloblastoma into 3 types, that is luminal, intraluminal, and mural, and also adding up one more type of malignant ameloblastoma, that is metastasizing ameloblastoma. And finally, when we move ahead, a comprehensive view is being given in 2017, which says ameloblastoma, that is your conventional variety, can be seen 75 to 85% of cases. The unicystic ameloblastoma comprising of 15 to 20% of cases, and extraosseous or the peripheral ameloblastoma comprising to 1 to 4% of cases. Now, moving on to conventional ameloblastomas, we all know, this is just a quick revision I'm taking up. It says that it gives definitely a variety of histological features. It is multilocular in appearance radiographically, and what we have is histologically, it could show follicular plexiform and can simultaneously show cystic, granular features, acanthomatous features, spindle cell, basal cell, clear cell, or even the hemangiomatous forms. These are a few pictures. Here, the first one, it is a combination where we can see the follicles and some type of anastomosing strands of plexiform variety, follicles undergoing cystic degeneration, and some amount of acanthomatous transformation. This is the picture of the unicystic ameloblastoma, where we can see the intraluminal growth where follicles are undergoing acanthomatous type. Then here we have the basal cell type, and here the granulomatous transformation type. Again, just a quick revision. Coming up to the unicystic variety, this is the second most common type, and it is mostly encountered in younger age groups. And of course, the average age being around 26 years. And we have 3 histological variants. Then coming to the peripheral type, which is the least common type comprising of 1%, more commonly seen in mandibules compared to maxilla, and the posterior gingiva, alveolar sulcus, or the buccal mucosa. Now, this is from one of my article where you can see the panoramic view of a multilocular cystic lesion with expansion of bone. But on CBCT, as you can see, there is no bone perforation. And what we could see is we could see a variety of histopathological features in this particular case, which comprised of both follicular, plexiform, desmoid variety. We could also see neoplastic or metaplastic bone formation. We could also see some kind of cystic proliferation, the granular cell type, the acanthomatous type. Now, a desmoplastic variant, as I told you earlier also, it has been removed from the classification and has been put into the histological variant. It comprises basically of extensive stromal dysplasia. There is extensive stromal proliferation, which compresses the proliferating follicles as well as the anastomosing strands, giving them bizarre shape. And because of its high invasive behavior, what we could see is we could see large metaplastic bone can also be seen within this structure. So radiographically, it accounts for both radiolucent as well as radio-opaque features can be seen. Now coming to metastasizing or malignant ameloblastomas. Now this metastasizing ameloblastoma basically arises from a previously benign lesion, and it metastasizes to the distant site like lung, which is the most common site, or could metastasize to cervical lymph nodes. Now, this particular lesion accounts for less than 1 to 2%, and it usually occurs over a decade after the treatment of primary ameloblastoma. The other sites where ameloblastoma could metastasize, these metastasizing ameloblastomas account for 1 to 2% of the cases, and they usually occur after almost after a decade after the treatment of primary ameloblastomas. And they have similar histological features. Probably that was the reason where it has been said that a benign lesion is metastasizing, and the other areas where it metastasizes to could be vertebrae, pleurae, skull, parotid gland, diaphragm, and liver. Now, it has also been seen that in malignant ameloblastoma, in metastasizing, okay, next in this category would be the malignant ameloblastomas. Now, there is a very little differentiation between these varieties, where the malignant ameloblastomas basically show a cadron switch in development. That is, E cadrons are getting converted into N cadrons, and there is transcellular intravasation. There are two processes which are occurring. There is transcellular intravasation and paracellular intravasation, with various cytokines coming into the picture, leading to metastasis. Ameloblastic carcinomas, they are locally aggressive. They could develop as primary a lesion that is developing as de novo, or they could arise from the secondary intraosseous lesions or secondary peripheral lesions. And they have the overall histological pattern would be very similar to a benign ameloblastoma, but along with that, we have cytological atypia consisting of abnormal mitotic activity, cellular and nuclear hypochromatism, and focal necrosis, which could be identified. Now we come to the management modalities and how far we have moved into the management modalities. It has been seen that diagnostic imaging have been used over the period of time. That is, we have started with our occlusal radiographs, then panoramic radiographs, and moving on to conventional computed tomography. Now, conventional computed tomography has been of great help in three-dimensional diagnosis of structural expansion, because it accurately defines the radiodensity and marginal details of ameloblastoma, crucial for treatment planning. Then over the years, there has been development, and what we have got to see is cone beam computerized tomography. Now, this particular thing has really helped. It gives us a three-dimensional view of not only the soft tissues surrounding the lesion, it also shows the bony involvement, depth, as well as it also shows the nerve path involvement. Then MRI, that is your magnetic resonance imaging, is also of great help, as it gives us an insight of bone marrow and soft tissue components within and beyond the lesional margins of ameloblastoma, particularly useful in diagnosis of maxillary lesions which are there to delineate them from sinuses, orbits, and skull. And then coming on to PET-CT, which is a functional kind of an analysis, which is your positron emission tomography coupled with conventional tomography. And it is more so ever used in malignant ameloblastomas to identify their extension in soft tissues and infiltration in distant metastasis. However, these diagnostic imaging can be used together for evaluation, diagnosis, and treatment planning. But ultimate standard of diagnosis is biopsy, which remains the gold standard. Now we move on to the treatment part, that is the surgical approaches. Now, surgically, it could be treated conservatively or radical surgery can be advocated. Now, the conservative surgery basically deals with enucleating the lesion, cauterization, curettage, cryotherapy, marsupialization. Now, this particular kind of treatment is usually advocated in peripheral and unicystic ameloblastomas, which are unicystic ameloblastomas, that is your luminal and intraluminal, not going on to the aggressive variety or the mural variety. And it is most commonly treated, the conservative treatment is used in pediatric cases, depending upon the extension. In unicystic ameloblastomas, it could be treated with a conservative approach with peripheral osteotomy. Now, the radical surgery is advocated by doing end block resection with wide free bony margins, followed by immediate or later reconstruction of surgical defect with tissue grafts and prosthetic rehabilitation. Now, this particular thing is definitely advocated in conventional type of ameloblastomas or the solid type of ameloblastomas. Recurrence rate, as that I will discuss with you at a later stage. Coming on to the non-surgical approaches. Now, this involves radiation therapy. Radiation therapy in combination with surgery and chemotherapy is advocated, or it is advocated in cases where the surgery is not advocated, particularly in geriatric patients, or where with patients with comorbidities, or if patient denies surgery. So the various types of radiation therapy comprising of helical tomography, image-guided radiation therapy, intensity modulated radiation therapy, and proton beam therapies have been advocated. Their use is mainly recommended in malignant ameloblastomas, ameloblastic carcinomas, the recurrent ameloblastomas after multiple post-surgical recurrences. Their contraindication is that there is a risk of developing future life-threatening malignant transformations can take place. Now, coming to chemotherapy, chemotherapy has also been used in combination with surgical resection and radiation, and various drugs are used in combination, that is vinblastine plus cisplatin plus bleomycin, or adriamycin in combination with cisplatin or cyclophosphamide, or doxorubicin with cisplatin, or gemcitabine with carboplatin, or various other drug combinations have been advocated. However, their efficacy is still being explored. Coming to our next treatment modality, which are our targeted drug therapies, and these are advocated in present time against the gene mutations, and they basically help in treating the areas of gene mutation, thereby causing less disfigurement, and they can be advocated at a very early stage where the swelling has not reached a Grottox sign. It has been seen that vemurafenib and dabrafenib has been used to inhibit BRAF gene mutation and thereby regulating MAPK pathway. Trametinib is also being used in mutated MEK gene inhibitor. Pontanib and regorafenib have been used in mutated FGFR2 treatments. Drugs used against SMO or smoothened are vismodegib and itraconazole. Arsenic trioxide and cadcyclopamine have been highly advocated against SSH signaling pathway. Now, all these have been used and the trials are still on, but they pose major challenge in developing resistance. At the site where the drugs are binding to these mutated genes, the resistance could develop. So trials are still on and they pose challenge towards their effectivity. Now coming on to recurrences. Recurrence again in ameloblastoma poses a major challenge. Now this could be due to the local invasive behavior, different histological variants with peculiar tissue components, treatment approach, and how early the patient presents for treatment. It has been seen that high rate of recurrence is seen in conventional ameloblastomas, particularly if they are conservatively treated. And conservative surgery, if advocated in malignant ameloblastomas or ameloblastic carcinomas, would also lead to high rate of recurrence. SMO gene mutations also appear to have high recurrence rate than other mutations which have been identified. So ultimately, the recommended treatment for recurrent ameloblastoma is radical surgery with wide disease-free margins and regular follow-ups, which is to be advocated, thereby giving a disease-free life to the patients. I hereby sum up my presentation that as the etiopathogenesis is evolving, the histopathogenesis, which plays a key role in diagnosis and giving an insight for treatment, the treatment modalities are also evolving, and yet no conclusive therapy has been advocated. The process is still under continuance, and we definitely hope to see some more research in this area for definitive treatment. Thank you.
Thank you, Dr. Priya Sahani, for an excellent information about the recent work that is going on related to the ameloblastoma research. And if you permit, I think there are a few questions from the participants. I will try to put those questions to you.
Yeah, sure.
The first question is related to what is the trigger for the formation of an ameloblastoma? So I think it is it's a very broad question, definitely.
Yeah. But what I would say is the triggering factor, like basically now, as we are seeing in the present time, there is large amount of mutations which are occurring at various levels. So basically, it is the collection of these mutations, genetic mutations, and the host factor, which is responsible for inciting or triggering. Now, this host factor could be local or systemic again. The systemic could be immunosuppression or any kind of trauma or any kind of continuous repeated inflammation occurring in inflammation or chronic inflammation, which could trigger ameloblastoma. So basically comprising of local and systemic features, and of course the epigenetic reasons or factors in an individual.
There's another question, madam. This is related to the cyst like ameloblastoma, salivary gland tumors like mucoepidermal carcinoma and carcinoma, squamous cell carcinoma are all simply related to dentigerous cyst. So the relation is again, they wanted to know how exactly these things from a cyst, from a dentigerous cyst, how can they be transformed into these different types of diverse tumors, ranging from ameloblastoma to squamous cell carcinoma.
Actually, I would concentrate more on ameloblastoma rather than going on to other lesions.
Yeah.
What, according to my perception, dentigerous cyst, I mean, unicystic ameloblastomas particularly, they developed from reducing epithelium or from dentigerous cysts or dentigerous cyst surrounding an impacted tooth. So we have these modalities, all from long-standing solid varieties of ameloblastomas, that is your conventional ameloblastomas, which can undergo a cystic transformation. So particularly, we cannot rule out a dentigerous cyst component from this. So unicystic ameloblastoma, definitely we have to consider dentigerous cyst somewhere in the etiopathogenesis. We cannot rule out a dentigerous cyst. Although if we see histologically, when we examine unicystic ameloblastomas, we could see some non-specific areas at some times in our slide, showing some kind of cystic formation. But radiographically, if we identify unicystic ameloblastomas in association with an impacted teeth, dentigerous cyst cannot be ruled out.
Yeah. Yes, ma'am. Thank you. There is another question related to microRNAs. This is related to microRNA 489.
Yeah.
The question is to differentiate between a solid ameloblastoma and unicystic ameloblastoma. Is it possible to apply clinically to differentiate in case of inconclusive incisional biopsies? Whether to use this microRNA 489, but the results are definitely inconclusive in terms of even the scientific evidence. Still,
yeah, it is. See, I have given an insight of what research is on, and all this is not inconclusive. I mean, it is not conclusive at all. The trials are still on, the research is still on, and this is one of the evidence which is being found, which is seen that microRNA 489 is one such RNA, which is microRNA, which is seen in both the conventional type of ameloblastomas as well as unicystic ameloblastomas. So this can be expressed in both varieties. And it can be used in differentiating also from both. I mean, one moving on to another. Like, as I said, conventional ameloblastomas, long-standing variety, undergoing unicystic transformation. So this is expressed in both. Further research is still on. Nothing is conclusive.
Right.
Yeah.
And there is another question asking related to the difference between desmoplastic ameloblastoma and desmoplastic stroma in squamous cell carcinoma. They did not mention whether it is related to the behavior or what they wanted to look at exactly, but the question is they want to know the difference between desmoplastic ameloblastoma and desmoplastic stroma in squamous cell carcinoma. So maybe they wanted to, possibly it looks like the desmoplasia between these two, one is a benign lesion, benign aggressive lesion, another one is a malignant lesion. So maybe they wanted to know whether there is a difference or not.
What particularly, I think that this doesn't come under the platform of this. This question doesn't come under this platform, but still, what desmoplasia, as we see in ameloblastomas, is a factor for invasion. What it does here, what we see is the stroma, is what exactly the stroma is doing is we are seeing that the various factors the various matrix metalloproteins, what are they doing is they are degrading the collagen. And then finally, what is happening is, again, our bone remodeling complex. And what we see is expansion, invasion. And what exactly we see is we also see some kind of metaplastic bone. This is a broken bone, which we see around in this lesion. So we have both radiolucency as well as radio opacity in desmoplastic lesions when we examine them radiographically. I guess something, I mean, I did not go into the conversion of squamous cell carcinoma of how it will do. I guess the desmoplasia of the stroma would definitely lead to invasion. I mean, it would there would be again changes in the complex of proteins, the cadrants. Again, as I said, that there is a cadran switch. That is, E cadrants would get converted into N cadran, and there is invasion through para and intravasation level.
How common is the cystic degeneration in conventional ameloblastoma, and what would be the cause of it?
Common, again, as it all depends upon the how the lesion, how long is the lesion persisting. I mean, it is variable. It all depends on the presence of conventional ameloblastoma within the bone. I mean, for how long it is present. It is usually seen the long-standing cases would get converted into unicystic ameloblastomas. And what was the second thing which you asked? I mean,
what is the cause of it? What is the cause for the cystic degeneration?
The cause would be, again, all these, what I would conclude from all this thing is any of these genetic alterations which are occurring, you know, what is happening is they get collected. I would just like to say that there is a long-term accumulation of multiple genetic factors, and this leads to a mechanism following if there is repeated therapies which may eventually lead to aggressive clinical behavior. So basically, you know, repeated biopsies, if they are performed, or some kind of repeated trauma which is there in the long-standing lesions could lead to transformation.
Right, ma'am. Thank you, ma'am. There is another one. Does RAS gene mutation indicate the degree of aggressiveness of the tumor?
Yes, definitely. Yes. So it will.
Right, ma'am. Right. And is radiotherapy useful for tumors which are intraosseous?
Yes, basically we are using radiotherapy in cases where surgery, I mean, it can be advocated with surgery, or it could be used as a single entity altogether, where the patient compliance is not there. So that is the reason radiotherapy is advocated. So it can be used with intraosseous lesions also. Okay. Again, the risk factor is there. The risk factor is always associated, but this has been tried, and the trials are still on.
Right, ma'am. Right, ma'am. Okay. And what is your view on application of chemical cauterization for conventional ameloblastoma occurring in other than children? I think maybe in the adult patients, they wanted to understand the role of chemical cauterization.
See, cauterization, according to me, would not be should not be advocated unless and until the lesion is very small in an adult individual, and also in the cases of peripheral ameloblastomas. Peripheral ameloblastoma, small lesions cauterization, if they are diagnosed at a very early stage, the cauterization can be advocated. But if the lesion is large enough, it is intraosseous. Chemical cauterization would definitely not help. It would cause further recurrence and further aggressiveness of growth.
Oh,
so
I think the last one maybe we are dealing with, ma'am. Any possibility of concomitant existence of or coexistence of unicystic ameloblastoma and multicystic ameloblastoma?
Definitely.
So
Yeah, definitely. Definitely, there is a possibility. There is a possibility that multicystic ameloblastoma at one end and unicystic ameloblastoma. We have the possibility, but I need to check on this. I need to check the literature on this. That what is the percentage of it? And if there are any queries, they can contact me at my mail ID, and I will reply to that. But I am not sure of the percentage of occurrence of the unicystic with multicystic in concomitation. But there is definitely a possibility.
Okay, ma'am.
Yeah.
So okay, I guess I just thought. Sorry, Dr. Ravikant.
I think some of the participants are asking for your mail ID. If you permit, I think I can share that.
Yeah.
Yes, ma'am. Yes, sir. Definitely, Dr. Ravikant, you can share my mail ID, and if anything further, we can just go ahead and I can answer their queries. So.
Right, ma'am. Thank you very much. First of all, I need to thank Mandana madam for such a very nice initiative that will be useful for all the postgraduates, especially. And this is the first of it. I think very soon we will be seeing a series of these presentations with different faculty members who have actually worked in those areas. So, and thank you, Sahani madam, for such a nice
explanation. Thank you so much for having me.
And madam, if you could share the certificate.
Yes, definitely.
Madam, this is a small token of appreciation from our side for spending a lot of valuable time of yours for educating, for enhancing the knowledge for the participants here today. So this is our e-certificate. We will be sharing with you.
Thank you so much.
This is in the mail, ma'am.
Thank you, Dr. Mandana. Thank you, Dr. Ravikant, for this.
Most welcome. So thank you everyone for being here, for taking part. And what has been happening is that we had very good participation. We have had people from 11 countries, around 200 were registered, quite a few were on YouTube, and over 100 at any point were here. Sadly, we could not accommodate everyone, of course, because of the Zoom limitation of 100 in the room. But overall, it was very interesting. We had questions sent to us from yesterday itself. It was really great. Thank you, Priya, and a very nice session. Thank you, Ravikant, for being here and for moderating this. And now I will share your little certificate that is a very small token of our appreciation. Thank you so much, Ravikant. Thank you. I will definitely make it a point to share printed certificates with you all in due course of time. Thank you so much. Thank you.
Thank you, Dr. Mandana. Thank you, Dr. Ravikant. And thank you so much for giving me this opportunity. Thank you.
Yeah. Yes, Anila.
So I would just like to add that I'm so proud of Ravikant, my student, and Mandana, my junior, for conducting such a beautiful session. We feel like we are in a classroom or maybe in a hotel, a 5-star hotel, having a conference. It's so wonderful. Thanks a lot. Okay, both of you. I'm so proud of you.
Thank you.
I'm so proud of you.
Thank you. Yeah. Thank you so much. Yeah. All the support. It always makes a difference. Thank you.
Okay.
Bye everyone.
Bye.
Have a great day. Bye. Thank you for being with us. Bye. Bye.